So we are from Austin, Texas, actually a suburb of Austin, Texas, Cedar Park. And about 2 years ago, our son started struggling with depression, which led us to the pediatrician, which is the normal stop for a family with a child that's suffering with depression. And we got a normal, Zoloft, which is a normal drug for that a pediatrician would write. And then very quickly, he spiraled and needed to go to the hospital for treatment inpatient. We're admitted to the Children's Hospital for 10 days for stabilization, med change, psychiatrist for the first time, kind of dipped our toes in the water of what mental health looked like in Texas, thinking that we would end that treatment and we would go home on meds and our life would kind of truck along just fine. And that's not what happened. And frankly, that's not what happens with most families. About 85% of families that struggle with mental health don't just have one hospitalization, have many. And we were in that 85%. So our son Luke spent about 18 months in and out of inpatient facilities in the Central Texas area, changing meds. We found a great psychiatrist locally. And then just things didn't seem to improve. In fact, they seemed to get worse. In our research, actually through Facebook, we were able to find the Huntsman Mental Health Institute here in Utah. And it was a pivotal change kind of for his mental health journey, and ours as well. We had spent most of our time in Central Texas looking at having services, and so the thought of moving our son to Utah for treatment was a big step. We went ahead and did that in April of 2022. From the moment we stepped foot in the Huntsman building, things were different. The way that we were treated was different. We were seen as a family unit. They cared about our family. They cared about our child. They answered the phones. They always answered questions. So Luke was part of their CAT program, which was a comprehensive assessment and treatment program through Huntsman for the adolescent unit. So he was here for about 8 weeks last spring. And then after the spring, our family decided to move to Utah for the summer. Luke is one of 4, so my husband and my 2 younger boys and my daughter came to Utah for a few weeks, and we went through their outpatient program. At that time, we moved into the Ronald McDonald house, and we were able to be kind of a part of the Ronald McDonald family and spend time here. During that time, he went through Huntsman's Teen Scope program, which is an outpatient PHP, which stands for partial hospitalization, and received services there, which were amazing. Also, about the same time, we learned about Huntsman's mood disorder clinic, which is usually used for adults that are drug resistant. So about 15% of the population that suffer with depression, anxiety, or OCD, and even schizophrenia don't respond to drugs. So this was something we didn't even know was a thing. So about May of 2021, Luke started receiving electric convulsive therapy through their program. This was life-changing for him. He went from very unresponsive to drugs to responsive and not depressed within probably a month. So just a night and day change for our family at that time. Any type of illness for a child being ill is tricky for the entire family unit. Our family unit is, Luke has a sister. It's about 15 months younger, and then 2 brothers that are younger than that, 14 and 12. It's hard. It was hard balancing helping Luke and caring for other children. We luckily have a huge network and community of people that have come around us to help care for our other kids while we've been gone. But yes, it's definitely difficult on the family. It's unlike potentially cancer or another disease, that there's kind of a track, and this is what we're going to try first, and then if this doesn't work, we'll try this next. For mental health, it's kind of just like a shot in the dark. You try what you hope and doctors hope will work. And so for our younger children, we thought, one hospitalization and he would be home and things would be back to normal. And that just has not been the case. So at the beginning, you want to protect your child, unlike, them having pneumonia or COVID or cancer or whatever else. There was you could talk to other families that have kind of gone through that journey. With mental health, especially at the beginning, for about the first 6 months, we were very close-lipped and wanted to kind of protect our child or protect Luke in the sense that we didn't want him to be embarrassed or it to come back to him that he suffers with depression. So our journey in Texas was kind of by ourselves. We just kind of hit or miss. We tried to find the right doctors, the right providers, therapists, hospitals, and we very quickly realized there was differences between facilities. There were some facilities our family would not choose to go to at all. Oftentimes, unfortunately, those are ones that Medicaid pays for. We are blessed to not need Medicaid, and so we were able to choose higher quality care facilities for Luke. We kind of talked to other families that we thought had gone on this journey before us, looking for care facilities and residential facilities for their child that was mentally ill. Then we started letting a few friends know, and those friends led us to other friends that had kind of walked this journey. But still there was no great person or organization to look to this is the process you should look towards for mental health, unlike, like I said, many other diseases for children. So we took a huge leap, and once we got to Huntsman, literally when my husband dropped Luke off, we felt it was a different type of place for mental health. It seemed like doctors cared. Doctors wanted to know about us as a family. Social workers cared. They wanted to know anything about that might help this journey, figuring out what was kind of going on with Luke mentally. We had not experienced that in the past. And that continued. So after we left Luke here for the 8 weeks of CAT, doctors called us. Doctors called us on their own time. Social workers called us on their own time. And gave us their cell phone numbers. That just didn't happen other places. Huntsman's building for us is very special. It's a place that we, for the first time in 18 months, saw potential hope that we might see our child, the child that we had 2 years before, back after a very long journey of lots of hopelessness. And so that continued in outpatient, down to even the techs that worked in any of the departments, and the pharmacy workers and the lab workers. Everyone in that building seemed to care about us as a family and our son, which to us meant we were more open and willing to do even the hard work they wanted us to do as a family. So when we chose treatment in Utah, that meant plane trips, that meant long distance, back and forth. And we continue. So even we are still continuing once a month treatment here in Utah, which means we fly back and forth once a month, which means there's a huge barrier between our home and here. Luckily, we found the Ronald McDonald House, which became our home here. Without the right finances, for most families, what we do doesn't work. If we didn't have, middle-class jobs and jobs that were flexible, that allowed us to work virtually, this wouldn't have even been an option. Even Huntsman's CAT program, you have to put 2 weeks down, which is $10,000 a week. You have to write that check when you drop your child off. Most families can't do that. It's interesting, the difference between coverage for mental health and the coverage for, say, cancer. Even with insurance, we found definitely a disparity between what insurance will cover and private pay covers, and the quality of facility. We are super blessed. The doctors at Huntsman fought for our insurance to pay for all of Luke's stay, which did happen, which was not something we figured would happen. We figured we would be paying out 8 weeks at a time for the whole 8 weeks of cash pricing. So $80,000, which is overwhelming. It was overwhelming for us. It was definitely the reason we didn't go to Huntsman immediately. We found Huntsman in the end of 2021, and we chose not to go until 2022, but mostly because of the cost. We had seen facilities that didn't really do much, so we were like, are we willing to pay $80,000 to a facility in hopes that they will do more? We realized very quickly after talking to them that we were willing to make that gamble and willing to give it a shot. It was probably the best gamble we've made as a family. The best use of money that we've used is to come here. We were blessed to get a room at the Ronald McDonald House, which is sometimes hard to get into, about 3 or 4 days after we got to Utah. And we were welcomed by wonderful people at the front desk, and we just felt a peace at being here. We didn't know that these folks would be our cheerleaders for months to come. We didn't know that they would be friendly faces, that I would get to know staff on a personal level. When we entered the Ronald McDonald House, we thought we would be here for a few weeks, and a few weeks led to 8. And then I have come back for Lute to have longer treatment in the winter of 2023. And so I've been here for 8 weeks, and those same friendly faces are still here to offer hugs and to encourage us along the way. I think mental health for the financially disadvantaged is harder. In Austin, so few providers take Medicaid. So few providers take health insurance. So even with private health insurance, it's kind of a crapshoot who will take it and the type of coverage they will cover. So until that happens, until insurance companies kind of come around and say, oh, we need to provide for families that have mentally ill family members, we're going to be at a disadvantage, specifically in America. And I think in the US, in the world, because we've met families from other countries here as well. Everyone goes to the pediatrician first, like for anything wrong with your child. So I think the number one thing is pediatricians need to be aware of what's available in their cities. When we asked our pediatrician, what do you do next? They're like, just go to the children's hospital. Well, that's not really a great solution, because what happens in the children's hospital is they're full of mental health kids waiting for beds. So I think education for pediatricians, specifically around mental health, would be the first place to start. I think them knowing services, knowing providers, and potentially providers that take insurance would be the best start. After that, I think we need to pay social workers more. There's not enough counselors, there's not enough therapists to go around. And to allow social workers to treat patients across state lines would be helpful. That's not allowed right now in most states, because some states seem saturated with mental health workers, I think probably because they're paid better. In some states like Texas, there's not nearly enough. Training hospital staff, since ERs are typically the first place children go that are needing behavioral health, when they're severe enough needing behavioral health, training those workers, training those techs how to handle a child that's melting down, that potentially maybe has autism and a mental health condition as well. I think just training and willingness to know that you don't know everything and look to people that do. Link arms with people that know about mental health, and like coming to conferences to find out about more about mental health services in your state that you can point your patients to is important.
At this time, we're going to bring up the behavioral and mental health panelists. Please come on up. And that is, you've already heard from Patricia Aguayo, who's coming back up here. Please. Patricia is an MD in Psychiatry, Child and Adolescent, Autism at the University of Utah Health. We have the Reverend Andrea Kennedy, who is the staff chaplain at St. Mark's Hospital. And then these next two I'm very familiar with and I'm fans of Robert Loftus, LCSW, who's the clinical staff development educator for Huntsman Mental Health Institute, and Laura Van Hook, who is also in LCSW, whose business is Therapy by Design. Laura was also a seasoned veteran social worker of Primary Children's Hospital for many years as well. She was a mentor to me when I first joined this hospital. So thank you. Welcome our panelists to behavioral mental health. Thank you. All right. Laura, we're going to start with you.
Well, I wasn't planning to go first, but I guess I will. So I'm just going to share a little bit about what led me to be interested in family-centered care. It started before I can remember. I was born with tracheomalacia and was treated in the old Primary Children's Hospital and was in and out of that hospital quite a bit as a baby. At one point, I was there for about 3 weeks. And I was born in 1972, so now y'all know how old I am. And my mom shared stories about that with me so many times, the impact it had on her to like have her baby in the hospital and have everybody shoo her out at 7 o'clock at night to go home. And they'd pat her on the head and say, "You just need to go home and get some rest, Mom. We've got this under control." So she'd go home to her house and pace her house for the next, 8 hours until she figured she could wheedle somebody into letting her into the hospital to take care of her baby. And day after day, she would come in to a baby who'd been screaming all night. I was kind of a particular sleeper. To a baby that had been screaming all night with some unfamiliar nurse walking the floor, bless her heart, with a screaming baby, to come back to the hospital to rock her baby for 5 minutes to get her to sleep, to spend the day and be sent home again at the end of the day. And this hurt her mom heart to the point where she never really recovered from that. Yeah. So I heard that from her. And then once I can remember, my babysitter had a brother-in-law who had cerebral palsy. And I was able to see how that family gathered together and were present and available to each other and engaging in family-centered care before it was a thing, which inspired me to want to go into special education. I got my bachelor's in special education and worked as a teacher for a little bit and found the thing that I enjoyed the most was working with families and parents of children who had healthcare and disabilities. And so that's what led me to social work. And I was really lucky to go and get my master's at the University of Oklahoma where we were living. And our program was very systems focused. I didn't realize it was as unique as it was because that was the only master's program I did. But heavily focused on systems in general and on family systems in particular. And it made me passionate about how the impact of the systems we were in, family, community, all of that stuff that we talked about with the ACEs studies and all of that, really have on people's health, on the development of children, and on the connectedness and functioning of families. So I worked for a long time as a medical social worker here at Primary Children's, then transitioned to the crisis team and became really passionate then about behavioral health and the impact that families can have on each other as far as getting treatment, maintaining treatment, and just being healthy, not just from a physical standpoint, but from an emotional and mental health standpoint. So I now work with a lot of families and especially older teens and young adults in my practice. And we really try to focus on having a family component, sometimes siblings and parents as well, in treatment in mental health. And it's been huge to be able to support entire families and seems to really improve the possibility of people having the lives that they want to have going forward. So that's kind of my journey here in family-centered care.
Thanks, Laura. My name is Robert Loftus, and I have been working in social work for more than 30 years. And some days it really feels like that. Other days it's really nice. So the brief story of my journey is I started out answering the crisis line in one of the crisis lines in Salt Lake County in 1989 as a bachelor's level person, and I had no idea what I was doing and sort of learned by experience. And then got my MSW, started working in adult mental health, mostly with the severe and persistently mentally ill population. At the same time, doing some medical social work at Primary Children's, and eventually gravitating back to Primary Children's, where I became the manager of the crisis team until about 6 months ago. I switched to Huntsman Mental Health Institute, and I'm one of the people in charge of training the crisis workers for the 988 service and the crisis lines. And, that's been a really rewarding journey. When Maria Gamvaroulis asked me to do this panel, I kept thinking about the topic of family-centered care and how often in behavioral health, we're not about family-centered care very much sometimes. And, I know I have at least 3 witnesses in the room here that I can't deny that I've been one of those clinicians on occasion that come back from the emergency room after meeting with a family and saying, I can tell you what this kid's problems are. And, they're sitting in the room with them. And I feel a certain amount of trepidation admitting that. But at the same time, as I've thought about that a lot over my career, I've tried to say, what's the flip side of that? And I'm found sort of an unlikely inspiration in Homer Simpson, who what I like about Homer is he gives such bad advice, and that you can't help but think, if I did the opposite of that, I'd probably be a fairly decent parent, And but I think it's an episode where he's trying to explain to Bart his love of beer, and he says something along the lines of, beer is like the cause of and answer to all of life's problems. And so whenever I'm tempted to think that parents are the cause of kids' problems, I always try and do the flip side of that and say, actually, they're also the answer to these kids' problems. And, we don't exist in a vacuum. We live in families. We live in groups, self-defined families, however we come up with that. But I can tell you in my work training crisis workers, one of the things I apologize. One of the things that's touched me the most are what we call third-party callers. That's a really generic and term, but it's family members who are calling in on behalf of their family members and saying, I don't know what to do. I have a son who's suicidal. I have a son who is taking meth and is tearing apart my house, but I don't want to kick him out. I don't want to make him homeless. And just these heartbreaking stories. And what's been gratifying is trying to help train crisis workers to understand that they can help these third parties to help their loved ones. And that it's about identifying not what you can't do, because there's so much that we can't do, but identifying what you can do. And that's just kind of how I've tried to approach things. And anyway, that's my journey in a nutshell, and kind of why I'm passionate about, families should be involved in people's care.
Thanks. My name's Andrea Kennedy. I'm board certified chaplain, really recently board certified. I finally got past the last thing of my big long journey. So anyway, I work half of my week. I work in the behavioral health unit at St. Mark's Hospital. So I'm kind of lead chaplain on that unit. And then half my week I work with low-income seniors in 2 different independent living facilities that are owned by Episcopal Community Services, which is my employer. So my experience in behavioral health is during my residency, I worked, kind of wanted to focus there. I had a special interest in my heart to specialize. And then shortly after my residency, I was offered this position. So really, it's just so so touching and such a profound honor to get to be a witness for these patients on their journey towards healing. On average, a patient stays on the unit, I would say, between 1 and 2 weeks. And so the idea is for them to go through a journey that's supported by the entire interdisciplinary team, to where they can leave very, very different from when they arrived. Okay, so I get to lead a couple groups on the behavioral health unit. One is a spiritual support group, and one is an spiritual art and processing group. And so I wanted to share these are beautiful. There's no identifying characteristics from the patients, and I have their permission to share these. But this is some of their beautiful artwork, and this is a group I lead that I call Pockets of Hope. And so the idea is to create some kind of uplifting image to where, this is what I tell them, is like, when you look at it, you just can't help but feel a little bit better. And then to write a message to themselves, something that they want to be able to be reminded of after they discharge. So they can put this on their fridge, they can keep it in their car, they can have it in their purse. And when they start to feel kind of low, they can look at this and just be reminded of something. Maybe it's a powerful insight that they received during their treatment. Maybe it's something that they're really working on inside themselves. So they end up just so beautiful. There is good out there. Look at this sweet dolphin. So sweet. You are stronger than they think. I can do all things through Christ who strengthens me. In your darkest days, shine your brightest light. I love you. Focus on being in the present moment. You've got this. Okay, this one was for a group that I did, that I said, okay, so if you could give any gifts to your inner being, or to your soul or spirit, whatever you want to call that part of yourself, they can be anything. That could be wrap yourself in a blanket of stars. It could be, something that is non-physical. And so this is what someone created, all the gifts that she wanted to give her soul. And you can see in this, this is someone she was actually going to discharge in a few hours. And so she came to the group, and oftentimes this is like on their discharge day. If they come to this group, they often use it as a sort of celebration of their journey, of their healing journey, and kind of a representation of the culmination of everything, the ways that they've grown, the ways that they feel like they've transformed since they've been on the unit. And then I think that's the last one. And then I wanted to share, so from one of my spiritual support groups, we have, has anyone heard of the I Am poem? Anyone heard of it before? Okay, so it comes with prompts, and then they just complete each line. So it's like, I am, I feel, I see, etc., etc. And so this is one of my absolute favorite, I think it's one of the most beautiful poems ever written, actually, by one of my patients. And I do have their permission to share it. I am hopeful I'll find joy. I'm not going to be able to get through this without crying. I never can. I wonder, is wonder in joy? I hear joy is and can be found. I see people when they experience joy. I want to know joy where it exists. I pretend feeling. I feel I'm coming closer without pretending. I touch in spirit with light. I understand my light is real. I say thank you to this light. I dream of all light and love in joy. I try never to forget all my light has traveled through. I hope to make it stronger. I am keeping this light in me. So beautiful. The the role I see spiritual care, as far as it relates to behavioral health and family-centered care, is really the essence of family-centered care, from my understanding, is about listening deeply to the patient, to the families, getting to be present and see them in a very, very holistic way, and listen to all the things that they're saying and help collaborate with them and help them participate in the decisions about their care. And so the role that I see spiritual care playing is, there's a part of all of us that can't be seen. The part of us that is involved with things like love and hope and transcendence, forgiveness, questions, existential questions like, am I worthy? Do I belong? Why is this happening to me? So spiritual care providers are really there to hold space for all of that. And then to get to hold space for someone to spend time with that part of themselves, I think is a very, very important part of holistic care and family-centered care specifically. So that's my little spiel.
It's me again. So my third hat I wear is in mental health. So my journey to family-centered care started with my own family. So as I shared before, I have a young adult now with autism, with significant behavioral problems, was kicked off kindergarten as well, kicked out. And I shared before, nobody really asked me how I was doing. And I was hanging by a thread, honestly. Very hard. That's why I ended up in this line of work, because I thought there were no one to help these families. But anyway, in time you meet good people that help you and teach you and you learn. But I work with families that have kids with autism or intellectual disability, genetic syndromes, all those kids that have a lot of things from the day they get placed on earth, and their families have to do that. So I think having my own experience has helped me be a better provider for these families. So I'll tell you about my fantastic program, if I can have my slides. So we're under Huntsman Mental Health. It's called the Home Program. Some of you may know about it. It's a medical home for kids with disabilities and autism. And we follow our patients through lifespan. So once you're in, we have 2-year-olds and 80-year-olds that we take care of. And that's our model of care. Patient-centered or family-centered, right? We provide all medical and psychiatric care in-house. So these kiddos struggle a lot going into new places, new people, new facilities. So they always come to the same place. Everybody knows them. So in time, sometimes it takes a year for them to come in and feel okay, but everybody gets there. And we all know them and they feel comfortable there. We take care of all of their medical needs and psychiatric care. Most of these kiddos also have mental health. So imagine being in a body that cannot tell people what's going on in your brain and you're depressed. So we have an amazing team of providers that have developed skills to work with these complex but amazing individuals. I put in some of the billing and stuff so you guys understand how we work. Next. Our philosophy aligns with the patient-centered medical home. So as I was saying, we take care of kids and families, and then eventually we end up working with group homes and adults with disabilities. So I think my message is whatever that group of people are around that person, that's your family. So you have to work with everybody. Next. So we work with Utah Medicaid, and that's one of our problems. I'll talk about that later, but we work with Utah Medicaid. You have to be eligible for Medicaid, and then you switch your Medicaid to home Medicaid, which is managed by UHealth plans. And we are an MCO, so we are given a fee per patient enrolled in the program, and then we manage all of their care. So if they stay out of the hospital, we can stay financially sustainable if we minimize hospital and ER visits. So we take really good care of these patients and keep them out of the hospital as possible. 2021. So right now we have about 1,400 patients enrolled. Next. Case managers. So I call it the secret sauce of the program. All of these kids and adults have teams of people and multiple players that are involved in their life. And as I said, that's the family we have to work with. So I'm talking about schools, parents, aunts, the grandmother, the psychiatrist, all these people that are part of this person's life. So the way that we can manage this is through the case managers. So each person has a case manager, and that's their point person. So anything that's happening, we're having a crisis, they took him to the ER, we had a little outburst and destroyed the classroom, or whatever that may look like, they call her or him, and they figure out, okay, what do we need, how can we help them, and connects the providers that need to be involved in whatever's going on. We keep close tabs on our people, so we need to see them frequently. And sometimes visits are easy. Hey, how are you doing? The reason for this, I want them to feel comfortable. So even if it's like, oh, hey, how are you? Everything's great. See you in 3 months or 6 months. They're comfortable. We learn to see what they look like when things are looking good, so that we know immediately when things are not well, but they can't tell us, right? So they have to come in. We also have the ability, which I think is incredible because of our financials, to see patients together. So I can actually, in the same room, have the pediatrician, me, the psychiatrist, case manager. Sometimes we invite teachers, schools, whoever's involved in that person's life, and we see them frequently. Even if they're super, super stable, to stay in the program, they have to come in at least once a year, get a physical, see the psychiatrist. Okay, and then this is our structure and the services we provide. Kind of what I was saying. Next. No transitions, so I think that's kind of important for this population. Next. This is our team, so we try to offer all services in the house. And we work with the U, but since we're the payer, we can figure out whatever that patient needs and make it happen. Next. And then this is what I was saying. So believe it or not, we're in mental health and we're financially stable because we keep people stable and out of the ER and the hospital. So once they come into the program, we see this slope go down. Next. And our strengths, the biggest one, collaboration with families and caregivers, care coordination, being flexible and adapting to each individual's needs, community partnerships. All of these kiddos have so many people involved, so we have to stay connected and be on the same page. Next. Challenges, Medicaid, and I didn't want to speak up when we were talking about policy, but we are working with Representative Melissa Ballard on kind of like the waiver you talked about, but this is a waiver for kids with autism and intellectual disability, regardless of income for the parents so that they can access some of these services. So give her a call.
For those that might not be familiar, there's a book called the DSM, the Diagnostic Statistical Manual. It's what's used to kind of help diagnose and do things, regardless of people's outlook on that. I had a professor tell me once many years ago, he said, Orly, it's a matter of degrees, not kinds. We've all experienced depression, anxiety, stress, PTSD, right? We've all had it. It's a difference of degrees, not kinds. Even mental health professionals experience this too in good numbers. So, thoughts, questions, comments? You have an excellent array of mental health professionals up here.
So the question is, within Ronald McDonald House Charities, and I think within Primary Children's, we have all witnessed this dramatic increase in the number of families being referred who have children that are high acuity kids that need access to behavioral and mental health support. And the more that we are working to grow our own competencies in this area to be able to support families where they're at, the more we have come to realize that the families we're supporting in this that have kids accessing behavioral and mental health support are often, to your point, not welcome or not allowed to participate in the care of their children. And so my question is, where do you all see pediatric behavioral and mental health going in terms of if you see any shifts in embracing family-centered care? Because I know I've had many conversations with parents who are so upset that they can't be at the hospital with their child because we would never ask that of any other condition. Anyway, I just am curious where you think things are going in that direction and what the right balance is.
Laura and I were just debating about who should take this, but so I think there's some really exciting developments. Is Amanda here still? No? Okay. So I was just looking for the director of pediatric behavioral health here. But I can tell you so that there are some exciting directions, which is I've been in several meetings prior to my leaving primary where they would talk about, well, why exactly do we keep parents away? We let other parents stay at the bedside when their kids are sick and in the hospital. Why don't we let them stay at the bedside when their kids are here for behavioral health reasons? And I think, there's been a lot of questions being asked, and I can say that the model is changing. I think we're looking to allow more family support while someone is in an inpatient facility, and to me that's really exciting that they've been able to ask that question, because I think in the past that was a sacred cow that it's like, no, we can't let the parents stay here with them while they're getting care. So I don't know what else.
And my understanding is that as we're building, new hospitals and renovating the hospitals we have, that capability is going to improve from a physical plant perspective. But for sure, the research is behind it and the mindset is shifting. And we 100% agree as social workers that we want families to be with their kids regardless of what kind of treatment they're getting.
Beautiful. Other thoughts? Oh, go ahead.
So part of the treatment is working on yourself. I believe that's it, but I agree. And if there's safety concerns, you can have all these people there. The milieu, that's the treatment. That's basically what they're away. But I do see more integrating of the family into the treatment. So there's family sessions with the kid and the parents. And so I see that piece. And I think things are evolving to understand that. And the family is part of the healing. And many times they too have mental health problems that have been unaddressed. So I think we're starting to see that more, and we're integrating more. If the family is okay, the family structure, that kid has hope, like we've been talking about.
I would add that the models are also changing. There's new models that stabilization and mobile responses happening in homes now, where we're sending teams out to homes with a social worker, a peer support specialist, someone with lived experience, family member, and into the home to create a safety plan to help strengthen the home and community. And that can happen pre-discharge, post-discharge. It can be a diversion or deflection from inpatient care in the community. And there are a few stabilization mobile response teams in Utah. Intermountain is doing a couple of them, and some local mental health authorities are doing some of them. But it's a really promising model as well to help support families in their home environment as well.
Thank you.
This is kind of shifting a little bit, but we were talking earlier when I made the statement that it only affects Emmett, which is not true. We already know it's not true. But my question is from a caregiver perspective. We're met with so many physical and emotional and mental needs of our children. In my case, someone that's nonverbal. But when I go to get the help, for caregiver depression or caregiver anxiety, it's almost brushed aside. And I'm just wondering, I guess my question is that evolving? Is there change happening, in the social work communities and the world right now that will help caregivers like myself get the help that we need when we're experiencing the mental and emotional load? And if it's not happening, what do you think can change to open that door to where I can go and sit with a doctor and say, I'm really struggling with this. And it's not, oh, you just have a medically complex kid. Like, that's your life. Does that make sense?
Get a good psychiatrist. That's what I would say. They need to see this. I think it's changing a little bit more, but just describe your day to day. And they should be asking you, okay, tell me about your day. What does it look like? And no, you need to be strong for Emmett. And many times it happens to me. I see the mom is just like dragging herself, and the boundaries are not always clear. But I do ask, how are you doing? You seem a little depressed. Are you getting any help? She's not the patient, but if I see there's a problem, I ask, can I help you? Can I give you some resources? And they usually will grab any hand that you give them. So yes, and if it's not working out for you, find someone that does.
I can say that I think so. Many of you, or most of you, probably know that the national hotline exists now, 988, that you can call for crisis, and it's much easier to remember than 1-800-273-TALK, and it's even easier to remember than 801-587-3000. And so, that's really been a game changer. And I don't even think we know the ways that is happening. And, Huntsman Mental Health is in charge of the Utah state version of that. And I can tell you that the national training and the guidelines are very specifically focused on third-party callers, where we're instructed to ask them how they're doing. Hey, you've just related to me all these problems that you've been having with your loved one. How is that affecting you? And, I'm always fascinated because I listen to, tons of calls as I'm training crisis workers, and they turn to me and they say, who's the patient here? And I said, exactly. It's like you need to talk about this third party that's not there, that someone's concerned about, but the caller is really struggling. And so it's like, you're really doing, two kinds of intervention.
I was going to say real quick, depending on where you're at, spiritual care services, that's something that we're really, really focused on, is just being able to be there and for everyone that's involved. And so it might be the caregiver that hasn't slept in days, that is just weepy and needs to tell the story, needs someone to just listen hear the whole story, hear and help them with how they're creating meaning around it, and maybe guide, do like a guided meditation or something to practice, like something that's in body that will be grounding, that will be soothing to the anxiety and nurturing for the soul to kind of fill your tank back up. So just want to mention that reach out. I have a colleague who works here at Primary Children's who's amazing. And so I would call on the team if you can.
I'm honored to be here today from California, and I'm sorry I don't know the answer to this, but is there a reason that Utah seems to provide these services and have a system that I've heard about it for many, many years? I know people who've come to Utah for treatment, just like the family that we heard there. Is it a policy issue? Is it a reimbursement issue? It's such a beautiful setting. I mean, I would love. But I do know, and my colleagues from Ronald McDonald House Charities can know more currently than I do, but I know that we are seeing so much more of a need for support of families who have a mental health concern in their family. And this is probably one of our most developed chapters in this area. So part of me is just trying to understand, is there something more systemically there that I should understand about Utah?
Ooh. Oh, let's give it to one of the experts, one of the trauma experts. Yeah.
So you've got two state mental health leaders, former and now at Intermountain in the room. Utah has fewer pediatric mental health rights in some ways, that a parent can place a youth in a treatment facility until they're 18. Utah is also very pro-business. And so there are a lot of, when I was at the state, there were 167 youth treatment centers in the state of Utah. And the majority of those had no or very limited state oversight. And the Office of Licensing had some physical oversight, but there wasn't as much. And they didn't report up through the Division of Substance Abuse and Mental Health. And that was something that we were working on. And there have been some policy changes since, but it was very much they had the University of Utah do a review that they bring in, all these millions of dollars to the state a year. So the legislature is very pro-business, but I have a bias against them.